If you're having trouble finding it, you can also hit the Alt key. Hey, Doug.
Hey, I was wondering, is there a way that I could maximize my viewing um, in this conference that it's something that I can adjust or not see so many names and stuff?
So we recommend changing two settings for your Zoom meetings. The first is hide non-video participants, and the second is change your view to gallery view side by side.
Okay. How do I do that?
So to hide non-video participants, you're going to take your mouse into the upper left-hand corner where you see a green shield with a checkbox. If you're having trouble finding it, you can also hit the Alt key.
Okay. So I found this box and now I left click on it. Okay. And it brings up the name of the meeting and all that information. What do I do now?
So the meeting information is open. Now you want to find the gear icon, which is your settings.
Oh, over on the upper right-hand corner. Okay, I click on that. And then my settings box comes up. Where do I go from here?
Hide non-video participants is a video setting. So find video.
Video.
And then this one's a little bit hidden. It's down at the bottom.
Oh, how do I get there?
You have to find the light gray scroll bar and scroll down.
Oh, wow. That's a tiny little thing on the right-hand side. So I scroll down and what do I click?
Now you're going to find the box that says hide non-video participants.
Okay. And then I just click out of here. And oh, okay. I see that you're the only person here. Okay. My name's disappeared. So it really cleans up the screen a little. Now, what if I wanted to see a bigger you, like if you were presenting, and see the PowerPoint or handout at the same time?
So we can change that, and you can adjust that pretty easily by changing your view to gallery view side by side.
Okay.
In your upper right corner,
okay,
just the opposite of where you were,
right,
you will find a view tab.
Okay, I click that. Oh, okay, and it gives me some choices: standard, side-by-side speaker, and side-by-side gallery. Oh, sorry, I accidentally clicked on side-by-side gallery, and I see that you're a little bigger, but how can I make it even more bigger?
All right, perfect question. In between, in the area in between what is being shown on the left, your document, and the video on the right, there you'll find a little slider there.
And when I scroll over it, a line appears up and down the screen. That's pretty cool. Okay, so I just do what?
Click on it and click and drag in either direction to make either side bigger.
Oh, I just made a really big U. And I made a slightly smaller U so that I could read what's on the screen. So it gives me the ability of having a lot of adjustment and control over my own video. Well, that's awesome. I learned a lot from this, and thanks.
Cheers, everybody. Have a good conference.
Good afternoon. I am Angela Humbertson, the current past president of Pendel AER and your current conference planning chair. We want to welcome you to the second day of the Pendel AER virtual conference. And we want to thank those who have attended the first two sessions in the business meeting. We'd also like to thank you to the conference planning committee and all the hard work they put into this. We look forward to seeing you at the awards and social event this evening at 6:30 p.m., where we will honor the recipients of the Richard L. Welsh Service Award, the Eleanor Long Educator of the Year Award, and the Student Scholarship winners. The full-day exhibitor event on Friday promises to be very informative and worthwhile. Some housekeeping items. There will be no opening code. We will only provide a closing code at the end of the session. The AV team requests that during sessions, please turn your video and audio off unless invited to turn them on by the presenter. Also, please change your name to reflect what you would like on your certificate of attendance. Registration is required for each session, so if you haven't registered yet, please visit our chapter website at penn-delaer.org. A certificate of attendance can be obtained upon request. The certificate may be used to submit to your employer for continuing education credits, such as Act 48. You should have already received the email that details this in a little more detail. It also has the link to the Dropbox folder where all the presenters' information and handouts and things are available. I will now pass the presentation on to Mark.
Thanks, Angela. It's my pleasure to introduce Dr. Marla Moon for the Ask the Doc session. Dr. Moon is in practice as a principal and founding partner of Nittany I Associates in State College. She's a graduate of Pennsylvania State University and the Pennsylvania College of Optometry, now Salus University. Dr. Moon's practice interests include geriatric, pediatric, patients with special needs, vision and learning issues, and all vision rehabilitation care. Dr. Moon has been a member of the American Optometric Association, AOA, excuse me, the Pennsylvania Optometric Association, POA, the Pennsylvania Optometric, and the Mid-Counties Optometric Association, MCOS, for her entire professional career. She served as president of the POA and MCOS and on various POA committees. She served on the Pennsylvania State Board of Optometry, 6 of those years as chair of the board. Dr. Moon was elected to the National Board of Examiners in Optometry and is currently serving on the board's Finance, Judiciary, and Examination committees. She served on the PCO Board of Trustees for 6 years and is a fellow of the AAO. She also served on the Penn-Del AER Board of Directors. Dr. Moon is also very active in her community. Dr. Moon was awarded the Dr. W. David Sullins Award by the AOA, which recognizes an individual doctor of optometry who has made significant contributions to optometry and public service involving the Infant C program. Her most notable contribution to the POA has been in the development of the POA's Kids Welcome Here, which is a pediatric vision care campaign. In addition, her peers named her the OD of the Year for both the Mid-Counties Optometric Association and the POA. In 1992, she was the recipient of the Penn-Del AER Distinguished Service Award. More recently, in 2019, Dr. Moon was awarded the Presidential Medal of Honor by the PCO and the Dr. H. Ward Ewalt Meritorious Award by the POA, the organization's highest award. She is also a fellow in the American Academy of Optometry. Aside from all of these wonderful accolades, Dr. Moon has been a tireless champion of students and adults with visual impairment and their families for as long as I can remember. That's a long time. Her unselfish and undying support to the field is remarkable, and it is often done on her own time. Marla is also one of the most passionate Penn State football fans on the planet. Before I hand it over to Dr. Moon, I just want to remind you that you have the option of submitting comments or questions for Dr. Moon using the Zoom's chat box. Dr. Moon, it's all yours.
Thank you, Mark. We've been through this a lot together. I still remember our days of going out on the streets of Broad Street and working with patients with various low vision devices and doing filter sun lens eval. So yeah, we go back a long way. All right, everybody, I'm gonna push screen share, and this is always the part that's the nervous part for me is the technical part. Everybody seeing my slides, I hope. If somebody gives me a heads up here.
Marla, I don't see them yet.
All right. Yeah, they're up on my screen, Greg.
Want me to pull up the PowerPoint for you?
Yeah, I think you're gonna have to do that.
Okay, got it.
I appreciate that. Backup. Gets back to the days where Mark was my tech person and I'd be pacing as the poor guy was trying to find a compatible projector to go with my netbooks or.
Okay, if you open up your Zoom, you should be able to see the PowerPoint now.
Yes, okay. Go on to the next slide. This is my contact information for you all. Even after this, feel free to get in touch with me. You will note there's stars around it. There's another email address from those of you that have attended or been in touch with me before. There's been several new layers of security that's been put on my office, my.com, and sometimes if it's not connected with an agency, sometimes I'm not getting emails. So if you use drmooneyes82@gmail.com, and again, feel free to provide anything at any time. Go ahead, next slide, please, Greg. Some of the things that were presented in the pre-questions that came in and topics that we'll be going over. We're going to be talking about eye care and eye issues and the unknown during the COVID. Are there changes that we are anticipating during COVID with children's vision or even adults for that matter, and even beyond? Well, we're also going to be looking at color vision glasses was a question that came up. Question also came up about retinopathy of prematurity. I'm going to briefly go over the new PennDOT bioptic driving regs. I've also included a summary sheet, but that's even still being developed. We don't have forms yet. The medical committee for the PennDOT are developing those. And then in the Dropbox, there are updated reference materials for those of you that have attended my presentations before. I usually have reference materials, everything from common ocular side effects to common medications, alphabet soup with terminologies and abbreviations that you may see in reports. So all of those have been updated and they're in the Dropbox. And then when we're all finished, if we have time, we'll open it to chat. I'm going to ask Mark to field the chat questions, but when you put a question in, please also put in your email address, because if we don't get to answer those particular questions at this time, I do want to get back to you with those. So if you furnish your email address, that would be great. As always, I have a ton of information here, so we'll field the questions, extra questions at the end. Greg, go ahead. A little bit of financial disclosure. Go ahead, Greg. Standard honorariums are usually accepted for some of my presentations. I do provide consulting to various agencies and organizations, and I do not accept any honorariums from pharmaceutical or product manufacturers. Next slide, please. Wow, the year of 20, what a year that was, huh? Next slide, please. Yes, that's the year of the COVID. Next slide, please. Well, everything was going good. On Monday, March 9th of 2020, I was participating in something that was sort of a dream trip for me. And Mark's introduction is a prelude to this. Next slide, please. I was on a trip that was a fundraiser for Special Olympics of Pennsylvania. It's their 50th anniversary, and they always have very creative things to try to raise money for their state games that are held here at Penn State University, except they weren't held last year. Next slide, please. And what it was a fundraising cruise. So as things were beginning to stir up, we felt that cruising was still safe. So a little under 200 people were part of this fundraising cruise that was hosted by a big Penn State family. Next slide, please. And so this is what I got to spend time with, literally dinner and drinks in the casino and at the swimming pool. All these individuals that I grew up with watching and supporting in Penn State football. And you probably recognize the guy that's, if you're into pro ball, the guy that's second from the left, that's Franco Harris. You know, what a dream thing. And the lady in the middle is the one that coordinates all this. She's the captain of the ship. And that's Sue Paterno, Joe Paterno's wife. Next slide, please. And the last night of the cruise was a dream dinner. I had dinner, private dinner with Sue on my left side and Franco Harris and his wife sitting across from me, and Lydell Mitchell, he's on the left end, sitting at the end of the table with his wife. And while we were on the cruise at this dinner, the captain came on to announce that when our ship docked in Miami, that the cruise industry would be stopped at that particular point in time. They thought at that time it was going to be 30 days. Next slide, please. So we got back to State College on March 14th and arrived back to a 14-day quarantine because that's what the CDC had put in. So what do you do in a quarantine? Next slide, please. I'm stuck at home. I haven't been home for 14 days, so-called do nothing. I can't even remember how long. And so many of you are also going through this as well. Next slide, please. So I did a lot of cooking. Cooking is not one of my favorite things to do, but it is if I have time and I'm motivated to do it. So I had my time and I had motivated. So I was cooking and providing food for some of my staff members, some other friends as well too. You know, went through projects at the house. How many closets can you go through and root out things? I even signed up for Facebook. One of my former employees who retired from our practice, she said to her little girl, she said, Dr. Moon must be bored. She now has a Facebook account. I got all my continuing education credits that I needed for my relicensure last year. A lot of them done during that time. I picked up a new activity, pickleball. I started doing some Zooming on the receiving side, not on the sending side. So my technical skills aren't so great. And then we got very busy with the National Board of Examiners. I was on the board for 4 years, the board of directors, and they do the preparation for those licensees, doctors of optometry, before they will get a license for respective states. So that was very, very busy because so too, with everything shut down, our examination centers were also shut down too. So here are these students that need to take exams to be able to get their license to practice. Hold. So as everybody, it was a challenging time in a lot of different areas. Next slide, please. So on Friday, March 20th, I'm still in my COVID, but Nittany Eye Associates, my practice, had to make some decisions. Next slide, please. At that time, we were notified that our offices, and we have 5 offices, would be closed as of that day. 75% of our staff had to be furloughed. The docs, we were suspended with regard to salary draws for an extended period of time. COVID policies and procedures were developed and staff were retrained for our startup. We scrambled to obtain protective equipment and cleaning supplies like everybody else. Toilet paper, paper towels, masks, they were all at a priority. Cleaning materials with alcohol or with Clorox. We made as many contacts to as many critical patients that we could. Also contacting agencies and referral sources just to let them know of our status. I used the time to develop new forms, templates. We did some minor repair projects in the office. We tried to keep in contact with our patients as much as possible. A lot of texting and emails and Zoom and patient education, and we'll talk a little bit about that as we go on. And we also started exploring HIPAA compliant telemedicine software. We tried 3 different software programs before we settled on one that worked for us. And there's some shortcomings with regard to that. We did find that in our area here, State College with Penn State University, we have a great infrastructure, but you go just 15 miles out of here and the infrastructure, it collapses. There is no Wi-Fi, very, very poor signals. You know, I've had patients that have had to drive to the parking lot of their local school to be able to hop on to their Wi-Fi. This whole process of COVID has really taught us a lot of things about some shortcomings that we have in a lot of different areas. Next slide, please. So Monday, March 30th came. Next slide, please. And this is our new uniform. We're masked. We have shields for some procedures. We have shields on a lot of our instruments, on our biomicroscopes, and we're all wearing scrubs. As soon as I come home, they go right into the washing machine. Next slide, please. So the reopening plan, we had to do social distancing at its maximum. The 5 youngest doctors were selected to begin to start to provide care. And believe it or not, I was one of the 5 youngest doctors because we had 2 that were on maternity leave. So we were just working 1 day a week. We were seeing patients for no more than 5 hours of patient care during that particular day. And we each had 3 staff members working with us, and they were unique. They could not cross over because we were concerned with regard to cross-contamination. Only our main office was open, and we were only able to see urgent care and emergent care patients. We weren't even seeing our own patients. So I was working on Tuesdays, and I could be seeing patients that were normally being seen by one of the other 10 doctors. When we first started up, the mask mandate was not in, but I started wearing a mask. And the first day that I saw patients, I had my staff and myself do the masking. And then I went to the front desk and I said, ask patients if you give them the option to wear a mask. After that first week, I made everybody wear masks that were coming in, and we all were continuing to wear masks. Then shortly after that, we got clearance from the governor and that we finally received a classification to eye care could be provided as essential medical services. So then we opened then the first week of May. That's how long we were down, from March 20th to the first week of May. And we divided into 6 teams. We could not mix staff. We could not mix locations. So I've only been in the branch office at Grays Woods starting at that particular point in time. We had to reduce patient density by at least 50%. Extra time was needed for staff to prep the rooms in between patients with cleaning and disinfecting. Cleaning and disinfecting glasses. Patients can't go in the optical department anymore and just pull glasses off and just try on tray, and everything has to be disinfected afterwards. even the doorknobs, no magazines. It's a pretty sterile area, but that's what we've had to do to stay safe. Fortunately, we didn't have anybody come down with any serious issues. My individual team, we had nobody that even tested positive for COVID. We've only had 2 that had symptoms tested and they came back negative. And because of this, and because of being in a branch office, all my specialty care equipment is at the main office. So I wasn't able to get back into doing low vision rehab services until mid-August, when I got to spend my first day back in the main office. And I didn't get back into providing binocular vision, functional vision exams until July. And then we've also had to be creative, like all of you, and think out of the box and come up with some options that we could do some virtual activities, virtual contact with patients, virtual follow-up, and even to do some vision therapy, vision rehab cases virtually as well. Next slide, please. Realize that us in optometry, we're not the only ones that were going through this. And this put a stress on the medical system to a point that there were many physicians, whether they were internal medicine, whether they were specialty care, that just decided during COVID that they were just going to close their practice and retire. Our medical center here had to reduce staff, and they actually eliminated positions during this period of time. So, you know, it really has put a stress on a lot of things. And we were talking a little bit a couple of days ago, and Mary Nell asked me to, you know, bring this up and share with you all what's happened with regard to the COVID and what challenges we've gone through as well, just like every single one of you have had to go through challenges. But one of the things that has really helped was the CMS gave emergency approval for services and billing in May to be able to utilize telemedicine, teleoptometry. And it's anywhere from a patient taking a photo and attaching it, phone calls, texting, or utilizing telemedicine virtual software, which we are using DoxyMe. And Rendia videos have been a big help, which I'll show you one of those. But it's really interesting. One of the most common things that have popped up during the early COVID time were styes, a hordeolum. And a lot of times patients didn't want to come in. They felt afraid to leave home. You know, they weren't even going to the grocery store. They were pulling up and having groceries delivered to the trunk of their car. But the reason why the increase in styes were occurring during this time were 2 things. One, styes are caused by staphylococcal bacteria. One was mask wearing. The circulation of air and the bacteria in that was causing that, and stress levels tend to increase styes. So we were seeing a lot of styes pop up during that time. But I've been able to contact and stay in contact with patients so well with regard to this. But let's talk a little bit about the Rendia video. Go to the next slide, please, Greg, but don't start the video yet. These are a series of educational videos that have turned out to be lovely during COVID. Say, for instance, I have a patient that comes in for an examination, and I determined that they have cataracts that are a point that they're medically significant and ready for surgery. Instead of having the patient be exposed and sit at my office for any longer period of time, I send them home. We set up a telemedicine appointment time, usually in the evening, and I send educational videos to them to review before we have our chat. That way they can have other family members, because we're limiting a family member if needed to come with the patient into their exam areas. So this way other people can see it, they can re-see it again. It answers a lot of questions for them. And then we can Zoom and talk back and forth through DoxyMe, and we can spend as much time as they want, whether they just 10 minutes or we need to talk 30 minutes about everything from soup to nuts. So we're just going to show just a short 29-second video, since I was talking about styes being a real common thing. This is one of the things that I would send out to patients after I did a telemedicine consult, even if they just sent me a picture over the phone and texted me with it to make the diagnosis and then send in their medication.
A sty develops when one of the glands at the edge of the eyelid becomes infected. Resembling a pimple, a sty can grow on the inside or outside of the eyelid. Styes can occur at any age. Affected areas are tender, with localized redness and swelling. They do not interfere with vision.
Thanks, Greg. Let's go on to the next slide. So that gives you a little sampling of what we've been able to do with regard to the videos, but they're all different topics: glaucoma, cataracts, different types of surgeries, binocular vision, what's vision therapy, low vision conditions. So now that's what we've grown into now. And that's been some of the positive things that have come out with regard to COVID. Was one of the things going into it and be in the middle of it. We weren't going to sit there and go, oh, woe is me, what am I going to do? We're going to try to make things better going forward. And that's what we've been able to do. But we don't know some of what the future is going to bring. And that's some of the things we're going to talk about now with regard to COVID. Next slide, please. So going forward, we're still wearing masks. If you look in the bottom left-hand corner, it says mask up or pack up. That's Penn University's motto. Vaccinations. We've all been vaccinated. As soon as the hospital staff got theirs, we were in the first phase. In fact, we were in the first day after they opened up for the general medical care community. So all of our staff are all vaccinated. We're still doing the social distancing. We're still avoiding crowds. You know, the most that I've been with any group of people is usually 4. You have my bubble group, so to speak. So it's all still important because we still have a lot of unknowns that science still doesn't know yet. So we're still trying to be all careful, just like all of you are. Next slide, please. So like I said, we still have a lot of unknowns out there, and we have a lot of unknowns with regard to what to expect with health things, but we also have the unknowns with regard to vision. And that's what we're going to be talking about now. Next slide, please. So COVID in the eyes. Next slide, please. We're going to talk about some ocular issues associated with COVID-19. Fortunately, there's not been a whole lot that has been found so far. And the one thing that they found associated with regard to COVID, that's one of the signs and symptoms, is a conjunctivitis. But we've always had conjunctivitis, but this is a little bit different type of conjunctivitis that has some combinations of allergic conjunctivitis and some viral conjunctivitis. This time of year and last year in the spring was difficult sometimes to diagnose. You know, you're having itchy eyes. We have that with allergies. You have watery eyes. That's with allergies. Sore. You can have that with regard to viral. Some of the light sensitivity goes with both. But the good thing with regard to it is it responds to typical treatment. Symptoms usually occur within 2 weeks of the other COVID symptoms, and it usually lasts for about 3 weeks. And it doesn't leave any damage to the eye in any way. And there was a recent article that came out a couple months ago in the British Medical Journal of Ophthalmology. They found that the occurrence with regard to conjunctivitis in COVID cases, positive COVID cases, was about 80%. So I'm sure there were some cases that we may have seen and treated conjunctivitis that may eventually went on to other symptomatology with regard to full-blown COVID. And again, the importance of us having to be protective of ourselves, but our patients as well. Next slide, please. Now, through this, they've been able to identify that the COVID virus in a small amount is found in the tear film. So the CDC went back and forth and finally determined that contact lens wear, there's no evidence to suggest that contact lens wearers are more at risk for acquiring COVID-19 than eyeglass wearers. Contact lens wearers should continue to practice safe contact lens wear and care hygiene habits. That's the statement from the CDC, and they're still sticking by that. What I found is individuals that are wearing daily disposable lenses, that's the safest way right now. And if you're wearing a monthly lens, disinfecting with a hydrogen peroxide system. Next slide, please. So again, we're going to find things as time goes on, but so far nothing big, but other COVID pandemic related ocular issues. There's indirectly one that has popped up. Next slide, please. And it's this one, that there's a possible central nervous system disorders related to COVID have been reported. They've typically been found in individuals that were critically ill, and they're acute necrotic encephalopathy, encephalitis, and or strokes. So those visual field losses, those signs and symptoms that are similar to what we see with traumatic brain injury patients, we could possibly see this as time goes down the road. So far, I've not seen cases, but it is rare, and they've only found this in the individuals who have been critically ill from the COVID virus. Next slide, please. So there are other issues that are popping up or at risk for during COVID that we're seeing. We talked about the styes, but the big one is dry eye syndrome, dry eye disease. Now, before COVID, this condition had been around. It was common in women. Women are 3 times more common than men because of hormonal changes that we go through. Everything else that dries out in our body, so does our mucosal membranes and our tear film. It was very common for individuals over 50 years of age. Again, that menopause stuff. We've also found too that computer use, when you are doing activities like a computer or driving for extended periods of time. Videography studies have been done at University of Houston and Indiana University in Bloomington that show that your blink rate reduces by 50%. It's the blink that squishes the tears out of the meibomian glands that causes them to be produced. So it's going to reduce your tear production. Certain medications we've always known that will reduce some of our tear production. Allergy, cold medications, they are a decongestant. So they're drying up your nose. Well, they're also drying up the mucosal membranes. Diuretics for heart blood pressure medications, and some glaucoma medications do a real job on the tear film. The preservatives tend to really dry out the tear beds. Sleep apnea, individuals that are on CPAP machines, because of the masking, the air circulates around and it tends to evaporate the tears from the surface of the eye. And then certain systemic conditions like rheumatoid arthritis or Sjogren's also. So that was all there before COVID. Now, next slide, please. So we're going to talk about some other issues associated with dry eye since the COVID. Next slide. This is the big one, the mask-associated dry eye. They even have a new name for it, MAID. We also have one in dermatology as well too, called maskne. Acne that's been developed because of wearing a mask. So if your mask is not fitting properly, not only are you having some tear evaporation going on, but you're also having fogging if you're wearing lenses or glasses. Because of that fogging, we've seen an uptick in 2 things in our office. One, the number of individuals asking to be fit with contact lenses. And the second is patients having LASIK surgery, because they're just tired of having their glasses fog up. Next slide, please. All right, so the additional things that have been going on with COVID that have caused the dry eye is online, virtual electronic devices, and other environmental issues. We're inside, we're not outside. I'm truly seeing this at all ages. My youngest patient that I've had to treat with dry eye symptoms has been 4 years of age, but it's very common between patients in 7 to 70 years of age. Again, like I said before, when you're using a computer and electronic devices, your blink rate reduces by 50%, but there are so many factorial conditions, multifactorial, multidimensional, that the treatments also vary from case to case. But just keeping general hydration is good. Those are the 2 biggest things I see with regard to kiddos that they have dry eye, or one, the amount of time that they spend on electronic devices and they're not taking visual breaks. And the second is they're just not hydrated. And if they are drinking, they're drinking things that tend to dehydrate them. Soda's just not going to do it. That's going to cause, especially if it has caffeine in it, that will dehydrate them. So one of the things that has been promoted pretty regularly with electronic use and even any type of near activities. You read a good book, practicing the 20-20-20 rule, which is for every 20 minutes, you take a 20-second break to look at something 20 feet away. Just that short period of time is enough to allow some additional blinking, allow your focusing system, your accommodative muscles to relax, and then go back down to what you need to do. Next slide, please. So COVID and screen time. Let's talk about this, because this has been a major issue with regard to kiddos. I mean, so many of our schools had to go virtual and shut down, and kids were being handed out Chromebooks, and people that didn't have internet services were issued hotspots, and on and on. You guys have lived it. I still after all these months, I don't know how you can do Braille readiness and teach Braille to a newbie virtual, but my hat's off to you guys. Next slide, please. So again, reiterating some of the things we've already talked about with regard to screen time. What's the visual problems? The dry eye, we've already talked about that, so we can check that off. But there's some other things. Myopia progression is individuals that have nearsightedness, myopia. Are the numbers going to be increasing? And the severity of the myopia, is it going to get worse? We're going to talk about that. And then we're also going to talk about blue light exposure. So many of our electronic devices have this. Is this a problem? Next slide, please. So let's talk about the myopia, the fancy word for nearsightedness. Well, this is not just the United States. This is an international problem. There have been a lot of research going on in this area, especially over the last 18 months. There are world councils and different research groups going on. They have believed that myopia is now a world epidemic, not a pandemic yet, but they have determined it to be an epidemic. And you will see from the data that I give you why they say that. It has now become the most common ophthalmic condition in the world. It used to be cataracts. Now it's not, it's this. So a person's nearsighted and you just wear glasses, see far away, and you're okay. It's a little bit more than that. About 35% of the world population right now is myopic. That's over 2.6 billion people. The frequency is increasing and is often progressive. The rate of nearsightedness occurring is faster than what it had been. And like I said, it's now being considered a global pandemic. Next slide, please. The frequency really has been progressing over the last 30 to 60 years. Back in the 70s, and I was one of those, the amount of nearsightedness rate in the United States was about 20%. In the early 2000 years, it went up to 30%. That's the United States, but in Asian populations, Korea, Taiwan, Japan, it's 80% of the population. And I see this here at Penn State University, being here in Center County, because we have the 10th largest Chinese speaking population in the United States. And so the number of Asians that we have that are connected with the university are high. So I'm seeing these numbers here as well. But these world councils and these world meetings are identifying, and this is numbers from National Institutes of Health, National Eye Institute, that they're predicting by 2050 that 50 to 60% of the United States residents will be myopic. Next slide, please. So another statistic, the prevalence of myopia in the United States between the ages of 5 and 19 is 42% now. They've determined that the fastest rate of growth of the eye, of the axial elongation and myopia, is between 6 and 12 years of age. That's the most critical time. But the earlier that we get it, the better. They're considering over 6 diopters is considered high myopia, and the problem with the high myopia is it significantly increases an individual's risk for future development of retinal detachments, retinal thinning, cataracts develop at an earlier age, and glaucoma. And we'll go into that a little bit more. Next slide, please. Retinal detachments, they're saying that the risks are anywhere from 3 to 20 times greater when we compare it to an individual that's not myopic. And again, it depends upon the level of myopia, whether you're a 2 diopter myope or you're a 10 diopter myope. Myopic maculopathy can result in vision loss. There's so much stretching that goes on in the posterior pole where the macula is that the choriocapillaris, the blood vessels there, start to break apart and leak. And it's sort of like what the end result is sometimes what happens with patients that have wet macular degeneration. But it's not due to that. It's just due to the stretching of the eyeball in myopia. And glaucoma, studies show that individuals with myopia have 2 to 3 times greater risk for developing glaucoma than people that don't have myopia. And cataracts, they just tend to develop at an earlier age. Next slide, please. So the risk factors for an individual to develop myopia, some we have no control over, but a lot we do. Genetics. We can't change the gene pool, but it does pose us to ask questions, additional questions to our parents that come in, even if they don't bring the kids in, and when they do bring the kids in, to ask, well, who else is nearsighted in the family? Because if you have one parent that's nearsighted, the kids are at 3 times greater risk for developing myopia. 2 parents, it goes up to 6 times risk. And even if you don't have any parents that's myopic, it's 1 out of every 4. And we're going to talk about some of those reasons. Ethnic background. We talked about the Asian population is significantly higher. It tends to be lower in Hispanic, Latin American, and Black population. The earlier the onset of myopia, the more severe the myopia. So if a child is 4 years old and starting to show myopic signs, the amount of myopia that they'll have by the time the eyeball growth is done will be significantly higher than, say, somebody that's 15 years old and first starts to necessitate glasses to see far away. We're also seeing research is showing that the kiddos that spend less time outside are at greater risk. So they're recommending, studies vary from 1 to 1, at least 45 minutes to 2 hours a day outside. And it doesn't have to be 2 hours straight. It could be a half hour here, half hour there. But the time outside is really making a big difference. And screen time, how much screen time, especially with smaller devices. There was an article that came out just a couple weeks ago that showed that using smartphones put more demand on the visual system because you're a closer working distance than, say, a PC or a laptop. Also, reading in poor illumination or lesser illumination also can speed up this process and develop onset. Again, there's something called dark focus. So the ciliary body, the accommodative system, has to overfocus the lens in such dim lit areas. And then premature birth. We've known this all along. When kiddos are premature, their collagen of the retinal system just tends to be a little bit more pliable and it tends to be more stretchy. And we're at greater risk for developing myopia in that. We've seen this with retinopathy of prematurity all along. Next slide, please. Some other things that can contribute to this. Again, some other studies are showing kids with normal vision spend 4 or more hours outdoors when compared to children with myopia. And another big thing for us in the Northeast, the progression of myopia is 3 to 4 times faster during the winter. And again, because they're spending more time indoors than if they're in Florida or they're in Texas. So because of these things, we're going to start, and researchers are predicting that we're going to continue to see this major increase in myopia because of the COVID as time goes on. But I'm happy to say that research is also coming out showing that we may have some things to help with this besides just spend more time outside, take visual breaks, use larger electronic devices, etc. Next slide, please. So let's talk about that. Let's talk about the first treatment to get Food and Drug Administration approval for the treatment of myopia. And this came out in November of 2019. Cooper Vision is a contact lens manufacturer, and they got an FDA approval for treatment of myopia progression in a contact lens called MiSight. It's a multifocal soft contact lens. Next slide, please. And it's been approved for myopia progression for children between the ages of 8 and 12. That's where they find that works best. Does that mean to say that we can't fit it in a patient that's 6 years old, or we can't fit it on a patient that's 14 years old? No, but that's where the studies came out, and that's where the FDA approval came. So it is the first. And the neat thing about it is, because of its design, and we'll talk a little bit about that in a minute, it decreases the rate of progression by about 59%. That's significant. If we can slow down progression of myopia to only a quarter or a half a diopter every 12 months, as opposed to a diopter and a half. So what I'm talking about is 1 to 2 steps of myopia progression versus 4 to 6 steps. And realizing that most of the growth is going on between that 6 and 12 years of age. Eye growth slows down in the teens, but it doesn't stop until late teens, early 20s. As much as we can slow down during this time, the better. Next slide. So this is how it works. If you look at the concentric circles on the left-hand side, the center is the distance prescription. And then the middle are these little blur zones. And you go, well, how do they get used to this? Well, actually 9 out of 10 kiddos do adapt to this. But what this does is those blur circles create a blur zone on the periphery of the retina. And we don't know how it works, but it does work, that it fools the eye so it doesn't want to grow. So it doesn't want to continue to elongate. By creating those blur zones on the periphery, what they call defocusing zones, tricks the eye to not to want to continue to grow or elongate. A lot of research in this. There's been several places all over the world that have been involved in this research, but Ohio State University is one area that just has a specific department just for this. Next slide, please. Not that I'm giving a support with a Penn State grad being Ohio State, but I got to give credit where it is. But that's not our only option, but that is the only one so far that has received FDA approval for myopia progression. I've been working with myopia progression long before that lens came out, and watching and monitoring kids and providing education to the parents. But there are some off-label options. One of the things with regard to that lens that we talked about, the MiSight lens, if a person has astigmatism and we need a toric lens, they don't have that option. And if a person needs a prescription greater than 6 diopters, it's not available yet. So we need to look at some other areas. So these are off-label options. Other lenses, there are a couple other manufacturers that do have a distance centered. That's the key part. The distance centered multifocal lens. So that means that the distance zone is right smack in the center of the lens, and then around the periphery, around the side is where the magnification comes in. Orthokeratology, putting lenses on that flatten the cornea that kids use and they sleep overnight with. It can actually reduce myopia to the point that they get about 8 to 10 hours of wear during the day that they don't have to wear anything. So think of it like a retainer for your teeth, for orthodontia. Atropine eye drops have been a very, very popular thing. They've been tweaking with regard to the dosing. This is a very, very low dosing in comparison to the atropine that we use for therapeutic purposes, to treat inflammatory or post-surgery, or even doing penalization when we work with kids that won't wear a patch for amblyopia therapy. The newest recommendation is 0.05%. And the drops are put in the evening. Initially, there may be some increase in light sensitivity or a little bit of blur during near tasks. That quickly goes away. This is a great option for kiddos that just aren't ready for contact lenses. Their parents aren't ready for contacts. We can do a combination. If the contacts are working pretty well, but we start to see an uptick in progression, then we can use the atropine drops. So we got a lot of different armaments now to try to keep those numbers below that 6 diopter range. Next slide, please. There's some other options that are coming out. They are available, but not in the United States yet, because you're saying, okay, you're using drops, you're using contact lenses, but what happens if you get a case that neither one of them, they can't stand having drops put in their eyes, they just won't wear contacts, parents don't want to put them in. So these are several ophthalmic companies that are developing eyeglass lenses. The Sight Glass Stellit from Essilor. Essilor is the #1 eyeglass lens manufacturing company in the world. It's a French company. Zeiss has Myovision. They're from Japan. Myo Smart Hoya is also from Japan as well. But I still don't know, and I've been asking questions why these aren't available in the United States yet. They're anticipating maybe within the next year we'll have this option. I've had 2 patients that actually have submitted my prescription information to Canada, and they've gotten their child lenses. They got the Sight Glass in Ontario, Canada. So it's something that's coming down the pike. We don't exactly have it yet here in the United States, but when it does come, it'll boom. It doesn't say that you can't do it. If you have a parent that's aggressive, they'll go do it. Next slide, please. So again, this is Hoya's product. This is how it works. It works very similar to when we were showing you those blur zones, those defocus zones of the contact lens. The clear center, and then the treatment zone is just a little bit of peripheral, creates that peripheral defocus zone on the side. There's a little bit of an adjustment that they got to go through to do it, but most of them do. 9 out of 10 do adjust to it. Next slide, please. Well, this was pre-COVID. This is myself with the NCAA National Wrestling Championship trophy before Penn State University was awarded this. This is the NCAA championships were actually down Pittsburgh. What an amazing, amazing experience. So for many years, we've been known for football as far as our sports, but we also have a monopoly now in wrestling. Next slide, please. All right, so one of the other things we talked about with regard to COVID and electronic device use, blue light exposure. Is this a problem, especially with the increased electronic device use? So let's talk about this a little bit. Next slide, please. There's several research areas that are going on with regard to this. There's a big research program going on in Canada, and also one in Hong Kong. But University of Toledo also has a research team, and this is the problem with regard to blue light. They've introduced retinal cells to other cells in the body, including heart cells, cancer cells, and neurons. When these retinal infused cells were exposed to blue light, they died. The team also exposed various cells throughout the body to green, yellow, and red light. And interestingly, none of those cells showed cell death. So one of the researchers is saying retinal generated toxicity by blue light is universal. It can kill any cell type. Part of this phenomenon may be because blue light has a shorter wavelength in comparison to other colors, and so it has more energy, more light energy. And the extra light energy can be the reason for the chemical change causing retinal generating toxicity. An ophthalmologist in New York City said blue light appears to damage retinal cells. It's still unclear how much blue light and for how long it's necessary for the damage of these sight-seeing cells to occur. We do know that the damage is irreversible. So it's the unknown. We know that they've been able to prove this in laboratory studies and in mice and rat studies, but we don't know how much is too much. So I'm educating my patients on the proactive, on the preventative aspects. So next slide, please. This is a big, 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 big problem. kids go off to bed. So we see multiple problems here for possible myopia progression as well. Poor light. We're looking at a small electronic device, and our working distance is reduced. So all those things can aggravate and result in greater risks for myopia progression. Next slide, please. So again, we don't know what the blue light exposure, what future issues are going to pop up for us. It is the unknown. Next slide, please. So like I said, I'm being proactive. I educate my patients with regard to this. I myself do the same thing as well. Next slide. So industry is helping us out. I was on a big webinar that they had over 500 people on from all over the world, including industry people. There were people there from Dell, people there from Hewlett Packard. And so industry is moving into putting in built-in blue light filtering system in their monitors. Now, if you have a monitor that's 5 years old or older, it may not have it. Apple was very proactive with regard to their phones many years ago, putting in an accessibility filter piece in there, but you have to turn it on. There's also blue blocking lenses that are available. Amber sometimes is a better filter. Photosensitive, especially the Transition brand. I went back to Transition lenses about 15 years ago because I get 100% of ultraviolet blockage, and I also get a blue blocker as well. Taking those visual breaks from the electronic devices is important, and stop the use of electronic devices at least 30 minutes before you go to bed is also important as well, because of the melatonin levels that blue light has been found to affect. Next slide, please. So again, I mean, the filtering processes don't eliminate all blue light because you need a certain amount of blue light, but they cut down quite a bit of it. So that this is how the works as far as blocking those rays that go through. Next slide, please. All right, so one of the other questions that popped up with the pre-questions was questions about color vision glasses. So let's talk about that a little bit. I have a little video. This is an optometrist in Minnesota. He has a whole series of videos, educational videos that are actually great. I haven't seen all of them, but he's got a whole milieu. I borrowed this from him because he does a quick, entertaining job on how color vision works before we get into the lenses. So I'm gonna hope this plays. There we go.
So did you know that 1 out of 12 men are colorblind and that 1 out of every 200 women have some form of color deficiency? Well, in this video, I'm going to be going over how color vision works, specifically how it's passed down genetically, as well as some eye diseases that can result in color blindness. Let's take a look. Hello and welcome to Dr. Allen here from the Dr. Eye Health Show, helping you learn all about the eyes and vision. And if you're new here to the channel and you like taking care of your eyes and seeing your best, then make sure to hit that subscribe button down below so that you don't miss any of my future videos. And this video is being part of color vision and going over color blindness. I do have a whole video series about different types of color vision glasses, color vision testing, all that sort of stuff. And I'll include that in a link in the description below if you want to check out the full series. Now, most people who are colorblind don't even realize that they have some form of color deficiency, and that's because they can still see colors. No, people with color blindness do not see the world in perfectly black and white. Instead, they see things more kind of a yellow or brown hue. And part of that is because there are many different types of color blindness. Most of the time, color blindness is inherited genetically. However, there are some toxicities as well as eye diseases that can cause color vision deficiency as well. The genetics for color blindness is carried on the X chromosome. So if somebody's father isn't colorblind, but their mother is a carrier for the gene, then there's a 50% chance that her son would be colorblind. And then there's a 50% chance that her daughter would become a carrier as well. But because it is a recessive gene, the daughter will only be a carrier and won't necessarily be colorblind. If a woman who is a carrier has a child with a man who is colorblind, there's again a 50% chance that their sons could become colorblind, but 100% chance that their daughter will at least be a carrier of the gene, and a 50% chance that their daughter could be colorblind as well. If a woman is colorblind and she has a family with a man who is not colorblind, all her sons would be colorblind, and that's because she's only passing on colorblind X chromosomes. And then her daughter would be guaranteed to be at least a carrier. But if a colorblind woman has children with a colorblind man, then all of their children would be colorblind. Does colorblindness run in your family? Is it carried by your mom, your dad, or both? Let me know in the comments. Now, most of the time when colorblindness is passed down through genetics, these individuals will have some form of red-green color deficiency. However, they usually still can see red and green. They just see things as different hues of red and greens compared to somebody who doesn't have color blindness. Now, color vision works within the eye because your retina has different cones that perceive the different wavelengths of light. There are S cones, which stand for short wavelength cones, and that pertains to different short wavelengths of light, such as blue light behind me. Then there's M cones for medium range of wavelength of cones. These are usually in the green color ranges. And then there's L cones for long wavelengths of light, which are more of the red colors of the light spectrum. A person who has all three of these cones functioning within the retina is known to have trichomacy, or what is called trichromatic vision. By far the most common type of color blindness is called anomalous trichomacy, and that's where one of these cones in the retina is not functioning as well as the rest of the two cones. You see, when the L cone is impaired and not functioning properly, such as in protanomaly, the sensitivity line shifts toward the M cone, leaving the difference between the two cones to be very small and hard to tell the difference between the two colors. Meaning this person has trouble seeing red and sees things more as green, yellow, and browns. A person with the M cone shifting toward the L cones, the longer red wavelengths, have deuteranomaly and will see more red normally and have difficulty seeing the green colors, again because the M cone pertaining toward green colors is not working properly and is instead shifted closer to the red. It is possible to have tritanomaly, where the S cone is shifted toward the green and red. These people have trouble with blue and yellow colors, but it is rare and almost always acquired in some type of eye disease. There are some people who have more extreme forms of color blindness, and those individuals often only have two functioning cones in the back of the eye. We call that dichromacy or dichromatic vision. And these individuals are said to have protanopia, deuteranopia, or tritanopia. And I memorized that while I was in school because it says nopia in the back. And do they see the color? Nope. Now, if you're not sure if you have some form of color vision deficiency, I recently posted a video about color vision testing. If you want to check that out, I'll hook that up here in the YouTube card above, as well as in the description below, again, if you want to check that out. Now, if color blindness is inherited through somebody's parents, it's often very clear-cut and easy answers in color vision testing, and it's usually equal between the right and the left eye. However, if somebody develops color blindness through an eye disease, for example, then oftentimes the results are not very clear-cut. Has a little bit more variables in it, and it often shows a difference between the right and the left eye during testing. People can often have difficulties identifying colors blue and yellow if they are developing a couple of different eye diseases, such as cataracts, which act like a film inside the eye that block out some of these colors, including other diseases, particularly in the retina, such as age-related macular degeneration, as well as certain retinal issues caused from diabetic retinopathy. And I do have other videos covering these different eye diseases, so if you want to learn more about those, again, I'll hook a link up in the description below so you can find those easily. Now, most of the time, people develop red-green color vision issues because it's inherited genetically. However, you can still develop red-green color blindness due to other eye diseases, mainly issues with the optic nerve, such as in cases of Leber's optic neuropathy, or from some sort of poisoning, toxic event, or nutritional problems. Very rarely there are people who only have one cone in the back of the eye, or nearly one, and we call that having monochromacy. This is usually due to an inherited retinal disease called autosomal recessive achromatopsia, or it could develop from a lesion in the extrastriate cortex in their brain. And these individuals will normally go from having normal color vision going straight to having black and white vision, and that can be pretty freaky. So if you feel your color vision is changing, make sure to call your eye doctor right away. Another interesting form of color vision change could be that you see the saturation coming out of one eye to be very different versus the other normal eye. And oftentimes when someone presents with this, I'm honestly very suspicious of them developing some form of optic neuritis or swelling of their optic nerve due to multiple sclerosis. I never mean to talk about these eye diseases to scare people. However, if you are having color vision changes, please stop this video, call your eye doctor, and schedule an exam to be seen. You only have 2 eyes, so please take care of them. Hey, thanks for watching. If you learned something new today, smash that like button for me. Otherwise, if you want to learn more about color blindness, you can check out my full series by clicking or tapping the screen over here to the side. Or if you'd like to see other cool videos from Dr. Eye Health, go ahead and click or tap the screen down over here. Again, this is Dr. Allen here from the Dr. Eye Health Show, helping you learn all about the eyes and vision. Keep it.
Yeah, Dr. Allen does a great job with regard to those videos, and he enjoys them so much as well. Thanks for Cynthia for putting that link in the chat as well for anybody that wants to watch that. But like I said, he does such a fun job and can get that information out as a backup intro for me to talk about color vision glasses. There's a lot of lookalikes that are out on the market. You can go online and see, but the 2 most popular and the ones that really should get the most attention are the Enchroma lens and the Pilestone lens. And we'll talk about that here in a second. Go ahead, next slide, please. I'm going to break down each one of these. So the Pilestone, it is the lesser expensive. It's run about $100 to $150 for a non-prescription form. They can do some prescriptions. They are available online. There's an online color vision test. A couple nights ago, I took it and I came up with a mild red-green defect. And I've never had issues with colors before. And we'll see the comparison when I do the Enchroma. They have a return policy that's a 60-day return policy if you're not satisfied with the product. That's the same as Enchroma. But there's some questions with regard to the quality of the frame and some of the resolution qualities with regard to the lenses as well. It's sort of like you're watching TV and you have 2 TVs set up side by side. You have a regular TV and you have a high definition TV. You can watch TV on both of them, but one really pops and the detail is just so much greater. Next slide, please. The Enchroma, it truly is the father of color vision glasses as we talk about it today. They do have an online vision screening. You can do a color vision. And last night I did, and I came up normal on that one. So I came up as a mild red-green deficit on Pilestones, but I came up normal on Enchroma. It's typically obtained from certified optical centers across the country. There is a certification program that the opticians and or the doctors have to go through. If you go to their website and you punch in a zip code, you'll pick up who is in your area. Our office is one that's a certified optical center. We have 2 opticians that are certified in it. Costs are more. They're about $200 to $300 for a non-prescription, but we can also get a variety of prescriptions, including progressive edition lenses as well. The quality of the frames are excellent. The resolution is very good. It has a non-glare coating on the front and back, and it's a Trivex lens, which is the most protective lens from an impact standpoint, and also Trivex also blocks UV light, 100% of UV. Enchroma has also come out with a low vision line as well to assist with contrast enhancement and glare reduction, and they have a return policy as well as the Pilestone at 60 days. Next slide, please. So a couple comments that I have from a professional standpoint with regard to the color vision glasses, they do not work for everybody. So it's best to go through an evaluation and actually experience it and look at the different filters. If it does work for the individual, it truly is a wow factor. I mean, that's probably the most common comment that they make is wow. But you do get what you pay for. And so that's some of the features that are the benefits with regard to the Enchroma quality of product versus the Pilestone. I wouldn't even bother with some of the other ones that are on the market. Corning glass. Corning had CPF lenses. They still have them. They also provide assistance for many of those cases as well. They've been available for about 40 years, but the downside of it is it's glass. So sometimes we have protection issues and weight issues. There's also some contact lens options, especially for individuals that have achromatopsia or cone dystrophy. What our laboratory has actually done is they've been able to tint the lenses to match like some of the Corning products and from the Enchroma if they want a contact lens option. But the downside is over time, the lenses will start to lose some of that color, will start to fade. So it usually doesn't work more for than a lens that's a 1 month disposable lens. Next slide, please. This is just a break in the action. This is myself. I'm actually doing SLT, which is selective laser trabeculoplasty, which is a treatment for glaucoma. I went through a certification program in Philadelphia to do laser procedures, surgical procedures 2 summers ago.
That's good, thank you.
However, the Commonwealth of Pennsylvania doesn't recognize that yet.
We're a little slow.
Next slide, please.
Can you hear it? Yes, I can. I don't know if it's like coming back off of the thing.
Thank you. The next question came up was about retinopathy of prematurity. Is it progressive? Do I consider it a progressive condition or not? So let's address that. Next slide, please. So my opinion, it depends upon the stage or the severity of the condition and whether retinopathy of prematurity was severe enough that it needed surgery or not. I don't so much look at it as a progressive condition versus it's at higher or lower risk for possible future issues. From the get-go, kiddos that have retinopathy of prematurity are at greater risk for strabismus, eye turns, and or amblyopia because of the pliability and the stretching of the retina from the retinopathy of prematurity process. They are much higher risk for developing myopia, and especially the high myopia. Because of the structure of the eye being a little bit on the smaller side, they tend to have narrow angles. And so you need to watch those cases for angle closure glaucoma. I've had 2 that have actually popped up within the last year and a half. And you know, again, it's just because their angles are narrow, and over time, they just further narrow a little bit more. Because of the stretching with regard to the retina, they're at risk for retinal detachments and or maculopathies. They're at risk for developing cataracts at an earlier age too. The one patient that I'm dealing with we've had treatment done with angle closure glaucoma. She's already starting to develop a cataract as well, and she's 31 or 32 years old. So again, I don't necessarily think of it as retinopathy of prematurity progressing as a condition by itself, but it's the risk factors that go along with it and the severity. So if you have an individual that was a stage 1 retinopathy of prematurity that regressed to 0, their risk factors are very, very, very low for any progression. If you have an individual that was a stage 3 or stage 4, then we have a high risk for progressing into some of these other things that we talked about. And hopefully that answers that question. Next slide, please. Since we're on the topic of retinopathy of prematurity, I wanted to bring up a new treatment. Retinopathy of prematurity primarily has been treatment utilizing cryotherapy or laser therapy, depending upon the movement of the new blood vessels, neovascularization, and the fibrous tissue. But there have been some studies showing positive effects if they're in a stage or zone 1 cases for utilizing anti-VEGF injections. The good thing about it is it doesn't leave scar tissue like the laser and cryotherapy. Primarily, it's just the peripheral area, but you know, still that's field loss that occurs in those particular individuals. But with the anti-VEGF, the vascular endothelial growth factor inhibitor, it causes the blood vessels to continue to grow in. That's been found to be a positive treatment mode for these particular cases. So this is a treatment that is regularly used for individuals that have wet macular degeneration. That's where it was first developed. And it's also been utilized for individuals that have some forms of diabetic retinopathy, especially if they have macular edema. But now we're finding that some surgeons, retinal surgeons, are using it for ROP and getting positive results. So just something to let you guys know out there that it's moving in that direction. Next slide, please. Next, yeah. The next question that came up was with regard to PennDOT Bioptic Driving Act 131 that passed. I'll go over it quickly here, but there is a summary sheet. There's still things that have to be determined yet before it becomes active in September, but we'll get into a little bit of it today. Next slide, please. Next slide, please. So it was actually House Bill 2296 that passed and was signed into law by Governor Wolf on November 25th. And it was actually a parent of a daughter who wanted to be able to drive with bioptics that went to this legislator that sponsored this bill, and it finally went through. The details are still being worked out. The forms are still worked out. As was discussed during the business meeting today, there's training still going on, starting to be developed with regard to this to get people up to snuff. We're still trying to develop coordination. I recommend that AER, we're trying to do as much networking as we can. The Pennsylvania Optometric Association has set up a task force, a bioptic task force. It's being chaired by Dr. Astorino from the Philadelphia area and Dr. Will Smith in the Pittsburgh area. That I would recommend that your association be in touch with the POA and that task force, so that way you guys can share information back and forth with your respective members. If you need assistance with the, please reach out to me. The medical advisory board and the legal counsel for the state are working a lot of that. There's one optometrist and one ophthalmologist that sit on that board. The optometrist actually happens to be Dr. Paul Freeman from the Pittsburgh area. But the biggest thing that we got to realize with this is just because an individual may be prescribed a bioptic or have a bioptic, it doesn't automatically mean that they're going to be a candidate to obtain a driver's license. So that's the first thing that we need to be very, very cognizant about telling our patients, our students, our clients. There's minimum requirements for this. The best corrected visual acuity has got to be at least 2200. And the visual fields requirement for general driving is in place as well too. A binocular field of 120 degrees, continuous horizontal. So if an individual has a central scotoma, they're not going to qualify for this. It's necessary that they have some color vision. So at this particular point in time, an individual has achromatopsia is not going to qualify for this. They got to be able to determine traffic light colors, pavement markers, road signs, emergency vehicle identification colors. Next slide, please. They have to possess a bioptic for at least 3 months before they go on to the next phase. It appears that the approved bioptic systems will probably be designs for vision and or an Occutech. 6X is the maximum mag permitted. There has to be a passenger in-car assessment after the bioptic is fitted, and at least 10 hours of instruction will be needed to complete that phase. Then they go on to the next phase. After that's been completed, which includes a low vision examination with a comprehensive eye health examination and plotted visual fields, the applicant would be eligible to apply for a bioptic learner's permit. Next slide, please. And then before permitted to take an examination for the driver's license during the permit period, they must obtain at least 20 hours of behind the wheel training via a certified driving instructor or certified driver rehabilitation specialist. After the training has been completed, they must complete a minimum of 45 hours of observed driving hours with a licensed driver at least 21 years of age. That's not too different than 16-year-olds are getting driver's license today. The hours are a little bit more. I think it's 30 for them. But 5 hours must be included in adverse weather driving conditions. And after all that is completed, then the candidate still must be reevaluated by the low vision rehabilitation specialist, which then looks over all those notes and all those observations and then determine to make the recommendation to PennDOT to schedule an on-road driving exam. And the driving time of utilizing a bioptic system can only be between 30 minutes after sunrise and 30 minutes before sunset, primarily daytime driving. Next slide, please. This is a sample of one of the bioptic systems from Designs for Vision that would be approved for this. That's about a 3X. Next slide, please. And this is Occutech system. This is one of their newer autofocus systems. But again, you see that everything is fitted superior. They're not looking through the telescopic system 100% of the time. They're using their carrier lens to get the general information. The telescopic system is only used for looking at the details of things. It's sort of like how we use our rear view mirror and our side view mirrors in our car. We don't drive the car looking through those mirrors all the time. We glance at them when we need information. That's how a bioptic system works for driving. Next slide, please. This is my favorite date. This was better than the prom. This is actually my nephew. This was in 2019 at the gala night when I got the presidential award from Pennsylvania College of Optometry, Salus University. So it's one of my favorite pictures with my great nephew. Next slide, please. All right, so before we wrap up some things at this particular point, I've updated the reference handouts. They're in your documents, in your Dropbox. Feel free to look at those. I have a summary of the bioptic driving in there as well, but keep your ears open and your screens on for your association as well, because more details will be coming out as we get them from PennDOT. Next slide, please. And so those are all the things that are in the handouts: the ABC Vision Checklist, observations for infant and toddlers, the alphabet soup that breaks down all these terms. When you're looking at a doctor's report, you don't know what those terms mean, those initials. Ocular side effects of the 10 most common prescribed medications, the current standards for driving, in addition to the bioptic summary, standards for hunters, vision and aging, what's the normal process, vision changes associated with traumatic brain injuries and strokes, and associated locations of visual field defects. Next slide, please. So I think we have a couple minutes with regard to chat questions. Mark, I'll ask you to field those for me.
Sure. There are a few questions. I just wanted to make a comment though, Marla, when you were talking about telescopes and you were talking about the maximum for driving is 6x. And, you know, I've worked with bioptics before with telescopes, and 6x is really pretty difficult.
Yeah.
I think people need to realize that the stronger the telescope, the less field you have to work with. So
yeah.
They are challenging.
Yeah. It's not only the lesser field of view, but also the amount of movement that goes along with regard to it and the jump that's associated with it.
The speed of the movement.
Yeah.
The speed of the movement.
Yeah. When you switch back and forth between the carrier lens and the telescope, it is very, very challenging. And also the eyepiece is also a little bit smaller in those. And when you have a patient that has nystagmus, or eccentric viewing spots, those would be some challenges for fitters, especially if they've not worked with bioptic systems before.
Yep.
There's a whole training program that the POA is doing they're setting up to do for docs as well. But Mark, I'm right with you. This again is something that's come out of PennDOT. I think patients are going to be much more successful in that 2 to 4x range, I think, is where most of the success is.
Yeah.
I found that before, even though Pennsylvania's not had the law, I've had to fit and certify individuals that have been longtime patients of mine that moved on to Ohio, that moved on to Colorado. So yeah, that's in fact both of those, the Colorado and the Ohio one, were 4Xs. So.
Well, here's a question, Marla, from Jamie. And she writes, we've received reports asking for TVIs to complete a magnification readiness program. Is there something specific paperwork wise, or do you mean training and practicing with different devices?
It's a combination of both, Jamie. It may be an individual that is not ready to utilize low vision devices yet because their skills are so poor that they can't even do spotting. So localizing and spotting, utilizing a paper towel tube, being able to handle a simple handheld magnifier or even a stand magnifier to get an idea with regard to how magnification works. There's sometimes some basic skills that need to be integrated even before I can do my best job or any other low vision rehabilitation practitioner to assess a specific power, dioptric power, or model of systems. And then some of it may then come into integrating that device into the individual's educational and living world as well. Hopefully that answers that question.
Okay, if not, I think Jamie knows how to get in touch with you.
Yes, she does.
Okay, from Jennifer, as this is just a comment that she had a patient with COVID that had a stroke and a lost left side field. So just
yeah, that goes along with that. Even though it's not been reported commonly, it's out there that individuals that have significant illness associated with COVID having the central nervous system involvement. And of course, strokes are one of them. So we'll start to see some of those pop up.
Okay, now Kara is asking, do blue light filter settings on cell phones actually work?
Apple has done research with regard to theirs, and Samsung, it does. Sometimes the level of absorption or blockage is not as high as others. Some are low. They may only be a 10 or a 15%. The maximum I've seen with regard to filtration, because remember, we need some blue light. We need some blue light exposure. But the maximum I've really seen has been in like the 30 or 40% blockage filtration rate. So that's more what you need to look at is how much.
Okay, good. Just a comment from Cami, you can adjust color filters on a lot of today's technology, which you just talked about.
Yep.
Here's a question. What specific app or book should be used on a functional vision assessment to check for color blindness?
Are we talking about for the PennDOT requirements, or are we talking?
I don't think so. This preceded your talk on the PennDOT stuff. I think this was on just as a TVI doing a functional vision assessment.
Yeah, sometimes it's we have various methods to do it in our office. Everything from the typical Ishihara, which is the standard. Burnell has come out with a kids one that's got pictures that the kids can trace over the outlines of whether it's a sailboat or whether it's a dog. We also have the Farnsworth test where they match up the color hues. But again, we're getting real detail whether you're telling whether you got a deuteranope, a protanope, or a tritanope. That's where you're getting into those particular details. But sometimes it comes down to just a labeling aspect. So I may have a series of 5 cards that are 5 by 7, and I'll see if the kid can you find one that matches this? Right. So you can do some of those trick kind of things with individuals that are nonverbal, but again, you need a certain level of cognitive aspects as well.
Yeah, exactly. Yeah. And I remember the I forget, was it Vision Associates years ago had a kit that had some nice functional vision stuff for color in it.
You're right, Mark. Yeah, they did.
And I know that I would always tell teachers, don't just go by one when you're doing color assessment. Don't go by just one test or one, because kids who are truly colorblind can match color because the density of the light dark density of the object is the same, but they may have trouble matching hues, which is why the Farnsworth is so good.
Yeah, and there's a couple other factors as well too. If you're looking, there's 2 reasons to look, or 3 reasons to look for perception issues. One, is its effect with regard to learning. And the second one is, do you have set up from a hereditary standpoint that the individual could have a color vision deficit? You can rule out many times just by doing a good family history. If the family has a color vision issue, well, then that child's not going to have a color vision issue. And then you start looking at conditions, okay? Like Dr. Allen had mentioned, there are certain disease processes. Like, for instance, when you get optic nerve issues involved, it tends to be blue-yellow issues. If you're having more macular or the hereditary aspect of color deficiencies, it's more red-green. So you can sometimes narrow down. I've had some kids that, mom doesn't have it, her father didn't have it, nobody in the father's side has it. So, I mean, you can eliminate your child's chance to not have if there's no eye health issues.
Okay, one last question, Marla. Have you seen implications from virtual games, headsets, or high definition TVs?
Well, several things. I mean, it's not permanent stuff so far. I mean, we talked about the dry eye situations. Where the studies are indicating with regard to those is the risk for myopia progression. But as far as actually damage to the eye, no, we've not seen that. If you can call myopia progression, not damage, but it really is. I mean, in some of those cases, and we're doing A scans to actually measure the axial length of those kids' eyeballs and see if it's starting to grow. I mean, for every millimeter it grows, that's 3 diopters more of myopia.
Right. Okay, Marla, I could talk to you for hours.
And I know, and I could talk about multiple topics for the whole time. But I really appreciate everybody's attention today. Hopefully I was able to share some good information. And I thank so much to Pendel AER and the committee for inviting me to do this.
Okay, and I'm going to shift it back over to Angela. So Marla, great seeing you. Thanks.
Thanks, Mark.
All right. Thank you, Dr. Moon and Mark. That was a great presentation. We've missed having you at our Ask the Doc sessions, Dr. Moon. I know it's been a few years since you've done those, so we appreciate you taking the time to join us today. So as we're a little bit over the time here, I have just a few wrap-up announcements and then we'll give you the code. So the conference committee would like to thank you for attending this session. There is one more session today. It's not worth any credit, but we definitely hope to see you there. It's the virtual awards event at 6:30 this evening, where we'll toast our award winners. Please bring your favorite beverage and we'll do that toast and hear their awesome little speeches that they normally give at the banquet when we're in person. And then also to remind you that the exhibitor event is tomorrow starting at 9 a.m. and then the breakout rooms will be in the afternoon at 1. So the closing code is reaffirm, REAFFIRM, reaffirm. And AV team, if you could play the closing slides, please. Have a good day, everyone.
Taking charge, restore, refresh, renew. This virtual conference is provided by the Pendel chapter of AER. We are glad you joined us. Pendel AER expresses deep appreciation to our guest presenters for their ideas, insights, and generosity. Terry Kelly, Kevin O'Connor, Robin Clark, Dr. Marla Moon, thanks for being on our team. Special thanks to the Pendel AER Conference Planning Committee. Conference Chair, Angela Humbardson. Assistant Chair, Aaron Weaver. Members, Gail Aquino, Dale Cohen, Brenda Egan, Debbie Holzoppel, Frank Erzik, Rebecca Knob, Greg Lazier, Maria Lepore Stevens, Helene Morano, Melody May, Tessa McCarthy, Mary Nell McLennan, Joanne McNamee, Vince McVeigh, Holly Russell, Mark Stechu, Emily Vasile, Tracy Whitehead, Doug Williams. All of our conference materials can be accessed through the Pendel Conference Documents Dropbox folder. There is a link on this slide. Please note that not every session offers handouts. This conference has been approved by ACV REP. We will announce a verification code at the end of each session. Details regarding continuing education hours and how to access a verification of attendance form are in the conference program. Please find this in the Pendel Conference Documents Dropbox folder. Pendel AER thanks all of our exhibitors for their participation and their support in this conference. Pendel AER thanks our techies, Greg Lazier, Doug Williams, Becky Knobb, and Patton for their time, resources, and support. Pendel AER thanks our communications committee for making all of our materials accessible. Join us in June when we present Billy Brookshire's Taking Care of Ourselves, Helping Us So We Can Help Others. The date and time will soon be announced. Pendel extends our special thanks to Icons 8 and the musician Gabriel for the song Belong. This is the song that played during the opening loop. The code for this session is reaffirm, capital REAFFIRM. The code for this session, again, is reaffirm. Thank you for joining us. We hope you will attend our 2022 conference in Harrisburg, Pennsylvania, April 27th through the 29th, 2022. A picture of the Pendel AER logo.